So good morning, all my respected seniors and dear colleagues. Today I will be talking on perioperative management of patients with antiplatelet and anticoagulant therapy, togetherly called as antithrombotic therapy. When we think of the patients with the perioperative medications, the medications can grossly divided into two groups. That is, medicines which are used to restore the physiology and the medicines which are used to alter the physiology. Almost all group of medications which are used perioperatively or the patients which we come across. These are the patients with medications to restore the physiology. Like in case of antihypertensive therapy, the aim of treatment to restore the hypertension, blood pressure of the patient to near normal. The same is true for the antiepileptics, antiarrhythmics, and all other medications. So when we are asked as an anesthesiologist what to do with these medications, the simple answer, continue, because we want our patient with near normal physiology. But when we come to other group, that is to alter the physiology, probably the only group which is used to alter the physiology is antithrombotics. It deviates patient from our normal physiology or patient's normal physiology. And here is the trick. We have to stop the medications because we want our patient near normal physiology. Now, whether to stop, how to stop, and if we stop, what to do. This is the all about this today's topic. So, coming to the background of the topic, we are now in a post-COVID era, and we have seen in peri-pandemic area that there were increased incidences of the thromboembolism events during the COVID, and the COVID was treated along with the antivirals, all other medications. There was rampant use of antiplatelet and antithrombotic agents. So, another is there is increased awareness of society about the coronary artery events and ischemic neurological events. So, this increased awareness automatically led patients to increased acceptance towards the prophylactic use of antithrombotic agents. Also, there is rise in geriatric patients with atrial fibrillation for different surgeries. Now, there are newer, safer, and specific anticoagulant groups are available for the treatment, and our clinical friends and clinicians are taking liberty to use them as per the antithrombotic agents for prophylaxis purpose. The patients with prosthetic valve and assist device with antithrombotic therapy forms the another group for this group. Now, what are our concerns when are dealing with these patients? When we see to the incidence and prevalence of the patients posted for the surgeries, simply when we look towards the patients with anticoagulant for atrial fibrillation, almost 10 to 15% of population require interruption of treatment for the surgery. Similarly, though we have many review literatures, repeated guidelines, updated guidelines, still there remains the dilemma when interrupting the treatment of the anticoagulation and antiplatelet, whether we are adding the risk of thrombosis or adding or bridging, whether we are adding the risk of bleeding. So straightway coming to the pharmacology, when we talk of antithrombotic therapy, they are grossly again divided into two groups, antiplatelet agents and anticoagulant agents. The antiplatelets, they are aspirin and along with its NSAID groups. The aspirin is age-old antiplatelet agent and it causes irreversible inhibition of cyclooxygenase 1 and 2 enzymes. It prevents formation of thromboxane E2 and platelet aggregation and thus acts as an antiplatelet agent. When aspirin is continued and it is bound to the platelet, it affects the platelet for its lifetime, that is 72 hours. And when you discontinue the aspirin, the recovery of platelet function occurs according to the turnover of the platelet in the body, and it is around 10% of platelet function recovery per day. The another group of antiplatelet group is commonly used is thienopyridine group, and clopidogrel, prasugrel, and ticlopidine are the drugs in these groups. These are prodrugs, and these are converted into active molecule when they went to the body. They causes irreversible ADP receptor inhibition and platelet dysfunction. Clopidogrel, when given 75 mg per day, 60% of platelet inhibition occur approximately 3 to 5 days, and the steady state is acquired in 7 days. Prasugrel, as compared to the clopidogrel, it is more potent, rapid, and consistent antiplatelet activity. Being a potent drug, it is associated with higher frequency of major bleeding risks. As far as loading dose is concerned, when 600 mg of clopidogrel is loaded, the antiplatelet activity occurs after 12 to 24 hours, while in case of prasugrel, it is attained in 2 hours. Another newer antiplatelet agents, these are considered as non-thienopyridine groups, and these are ticagrelor and cangrelor. Ticagrelor, it is famous, we know it as a Brilinta, and it causes reversible non-compatible G protein blockage. And after loading dose, antiplatelet effect is observed in as early as 2 hours with the ticagrelor. Cangrelor, which is mainly for parenteral use, and 95 to 100% platelet inhibition occurs in 2 minutes. And the recovery is also earlier as compared with the thienopyridine groups. And in case of cangrelor, it is 80 to 90% platelet function recovery occurs in 60 to 90 minutes of discontinuation of the therapy. Now coming the parenteral antiplatelet drugs which are used in peri-procedure time, these are GP2B3A receptor antagonists. Actually, all the antiplatelets acts ultimately to the GP2B3A receptors. The parenteral drugs are abciximab, iptifibatide, and tirofiban. These are commonly used during PCI in cath lab and acute coronary settings. These are as used during the procedure. These are commonly used along with the heparin and aspirin. And normal platelet function recovery occurs after discontinuation of the therapy. It takes approximately 8 hours for the tirofiban and iptifibatide, while 24 to 48 hours for the abciximab. Now, another group of antithrombotics is anticoagulants, and it itself is divided into different groups. The commonest is vitamin K antagonist. The newer one is direct acting oral anticoagulants. Heparin group. Under Perfusionist, we call it as a low molecular weight heparin, but it is indirect factor 10A inhibitor. The vitamin K antagonist, the warfarin, acenocameral, and fenprocauman, these are the common drugs belongs to these groups. It prevents reduction of the vitamin K, and reduced vitamin K is essential cofactor for formation of factor 2, 7, 9, and 10 in the liver. As we all are aware that these drugs are commonly abused because of their many interactions with the drugs, food, as well as the hepatic and renal dysfunction causes their erratic action. But the main advantage of vitamin K antagonists, they are relatively easier to monitor in terms of INR. Another advantage of the vitamin K antagonists, they have got definitive reversal agents like vitamin K, prothrombin concentrate complexes. These are factor 3 and factor 4 containing, and FFP depending upon the urgency. This is the only group of drugs approved for the anticoagulation therapy for patients with mechanical heart. The newer oral anticoagulants, which are named as direct oral anticoagulants or DOACs as in short forms, these are inhibitors of factor 10A, and commonly we come across the rivaroxaban, apixaban, and endoxaban. Dabigatran, which was introduced earlier and still it is in use, it is a direct inhibitor of the thrombin. The direct oral anticoagulants, they have shorter half-life, rapid onset of action, easier interruption and reinitiation treatment is possible with them, as there is a lower bleeding risk and they are shorter acting. There is no need or minimal need of laboratory tests for the monitoring of their action. Still, we have to keep in mind the hepatic and renal impairment of the patient. There we have to vary the time and duration of the interruption for these drugs. Another parenteral group of the drugs which are used as anticoagulants is heparins. The heparin grossly divided into unfractionated heparin and low molecular weight heparin. The unfractionated heparin molecular weight is around 5,000 to 30,000 daltons, whereas the low molecular weight heparin, they have molecular weight around 5,000. The unfractionated heparin, it is a antithrombin stimulant, and it causes the inhibition of factor 10A, 9A, and 10A. It can be used intravenously as well as subcutaneous route. The intravenous action starts immediately after the giving intravenously, while the subcutaneous, if the effect is attained in 1 to 2 hours. The half-life of heparin varies with the dose. As in 25 units of heparin per kg given, the half-life is around 30 minutes, while the half-life increases up to 150 minutes when it is given in 400 units per kg, as in case of cardiac surgery. The monitoring of heparin is easier. For smaller doses of heparin, it can be monitored in terms of FPTT, and for therapeutic, it is 1.5 to 2.5 FPTT is taken as an acceptable limit. ACT monitoring is done when heparin is used in a larger dosage, as in case of cardiac surgery. So one more advantage of unfractionated heparin is that it has got its own definitive reversal agent, that is protamine. And protamine, 1 milligram of protamine given approximately reverses the 100 units of heparin immediately. When heparin is used subcutaneously, the protamine supplementation should be given for a longer period. Heparin is abused for the heparin-induced thrombocytopenia, particularly when given for prolonged period or for more than 5 days. Low molecular weight heparin, as compared with the unfractionated heparin, it is safer, easier to use, but still renal dysfunction has to be taken into consideration. And when creatinine clearance is less than 30 ml per minute, its use is avoided. Now, we have discussed with the antithrombotics and the patients with antithrombotics. When we come across the patient, it comes to the evaluation of the patient. While evaluating the patient, few points have to be considered specifically in this group of patients. So what is which treatment patient is receiving, either antiplatelets or anticoagulants, indication of the treatment, which will show us the underlying condition, the duration of the treatment, which will show us the severity of the disease, hepatic and renal dysfunction. This interfere with the point of the time of interruption and duration of interruption, effectiveness of the treatment, course of the treatment, whether it was associated with the continued thrombotic events or any bleeding incidence has occurred, any previous interruption history, and the course of the interruption. That is, during previous interruption, whether it was done successfully, interruption caused any thrombosis or bridging caused any bleeding. Indication and urgency of the surgery. When you find it is threatening threatening thrombosis during the interruption, you think about the indication and urgency of the surgery and discuss with the surgeon. Need an assessment of the bridging treatment when thrombosis is impending or threatening. Any feasibility to postpone the surgery. Again, in case of if you have to interrupt for the surgery and thrombosis risk is more, any chances of postponing the surgery in discussion with the surgeon. Any safer and alternative mode of anesthesia when anesthesia is inevitable. Perioperative preparation, and now everything is inevitable. Then think of the perioperative preparation and availability of the blood products and any specific reversal agent in urgent cases. Now, how to determine the thrombotic risk? The thrombotic risk, when we determine thrombotic risk, the following subgroup of patients comes in front of us. Patients with atrial fibrillation, prosthetic valve patient, history of recent thromboembolism, venous thromboembolism, and recent coronary intervention. When it is atrial fibrillation, Chadwa score is taken into consideration. The score more than 6 is taken as a high risk thrombotic risk. The score more than 5 with associated risk factors like rheumatic valvular heart disease, stroke, or systemic embolism in last 12 weeks should be taken into consideration as a high risk patient. In case of mechanical valve, the position of valve is important. Mitral position mechanical valves is taken as more risk as compared with the aortic valves. The older case tilting disc valves were considered as a higher risk as compared with the newer bileaflet valves. The aortic valve per se, as compared with the mitral valve, taken as a low risk but aortic wall associated with additional risk factor like cardiac thrombus, cardiac thromboembolism, and history of stroke are taken as a high risk. Thromboembolic risk in case of venous thromboembolism, the provoked venous thromboembolism is taken with higher risk as unprovoked thromboembolism. The provoked venous thromboembolism means the patient with having definitive etiology, like patients with malignancy, orthopedic patient, long-time bedridden patient, or history of embolism patients are taken as a provoked thromboembolic. Coronary thrombotic events, these are very critical events, and it depends on the type and duration of the angioplasty. Acute coronary syndrome is always taken as a high-risk patient, and any ongoing cardiac events, in spite of the antiplatelet therapy, are taken as high-risk thrombotic event. Now, we determine that we are going to interrupt the treatment. Then we think of the bridging, and when we think of the bridging or we are going to the surgery, the next point comes, you have to evaluate the bleeding risk. Bleeding risk, the surgical bleeding risk can be calculated with the Hasbled score. The Hasbled score, simply, it is a mnemonic of patient with hypertension, increased risk, abnormal liver or kidney function test, stroke, bleeding history, or any predisposition for the bleeding risk, as patient with thrombocytopenia for anticoagulation, patient with any clotting factor deficiency, labile INR values, elderly patient, and patient on multiple drugs or alcoholic patient. These are taken as a patient with high risk patient. Generally, score more than 3 is taken as a high risk group. As far as procedures for the bleeding are considered significant, these are intracranial procedures, cardiac procedures, and neuroaxial blockage procedures are of more concern as far as bleeding is considered. Now, interruption of the treatment. While interruption of the treatment is considered, the patient population is divided into two major groups. One is patient for the general anesthesia, where surgical bleeding risk is taken into consideration, while the patient for regional anesthesia, our own techniques are can be threatening for the patient with bleeding risk, and mainly it is about the neuroaxial block. Regional anesthesia, when we consider about the regional anesthesia, we talk of the more of the deeper blocks or the neuroaxial blocks. It is always considered as a high risk group, and expert proposed conservative approach for these patients. Superficial blocks versus versus deep block. The guideline says that deep blocks are always treated as a neuroaxial block as bleeding risk is considered. Interruption of antiplatelet treatment. Antiplatelet treatments, we are always deferred from interrupting the antiplatelet treatments as far as coronary events are considered. The aspirin continuation is recommended for almost all guidelines, and reduction in when aspirin is continued, there is reduction in early thromboembolism, kidney failure, and perioperative mortality in CABG patients. Aspirin is also it is recommended to continue for the neuroaxial as well as the deep blocks. Mandatory DAPT is always advisable for 6 months for the new generation drug-eluting stents, and at least for 1 month for the bare metal stent. Bridging. As per definition, bridging is the substitution of longer-acting anticoagulants with the shorter-acting anticoagulants to reduce the risk of thromboembolism. So, which are the populations where bridging can be considered? Simply, the patients where the thrombotic risk is more, these are considered as a patient group for the bridging therapy. Which are they? Those are the patients with mechanical valves, as we have discussed, the mitral valve, AVR with additional risk factors, the patient with history of stroke, episodes of systemic embolism, venous thromboembolism in last 3 months, history of thromboembolism after the previous interruption therapy, or VT in spite of therapeutic anticoagulation. Patient with AF with CHADVA score of more than 6 or more than 5 with additional risk factors. Patient with recent history of coronary stenting within last 3 months, that is 12 weeks. The most importantly, bridging is not recommended for DOAC treatment due to their shorter interruption time and rapid reinitiation of therapy. Now, how to bridge? The 80 guidelines or these guidelines also agree with the ASRA guidelines 2018. Or as far as the vitamin K or warfarin is, vitamin K antagonist or warfarin is considered, the warfarin is discontinued on day 5 days before the surgeries. On day 3, restart with the low molecular weight heparin or unfractionated heparin, whatever suitable. 2 days before you check for the INR, if it is more than 1.5, think of the reversal with the drug or vitamin K. Discontinue low molecular weight heparin 24 hours before the surgery and unfractionated weight heparin 4 to 6 hours before the surgery. During post-operative course, reinitiation of therapy with vitamin K antagonist or warfarin is generally done after 12 to 24 hours, provided the patient renal function is normal and the surgery is having minor bleeding risk. Bridging for antiplatelet treatment. It has to be multidisciplinary approach and you have to discuss with your treating cardiologist. Continue it aspirin treatment as previously told. And ideally, DAP, dual antiplatelet treatment is not, it should not be discontinued unless surgery is demanded or surgical bleeding risk demands it. It can always be replaced with the shorter acting anticoagulants like low molecular weight heparin or heparins. Intravenous antiplatelet agents like in high risk group disease, glycoprotein 2B3A inhibitors can be used. A few case reports have been shown that shorter acting intravenous GP2B3A receptor inhibitors like cangrelor can be used in these groups. Emergency reversal of anticoagulation. What if the bleeding occurs in presence of the anticoagulation? Vitamin K given 10 to 30 milligram IV slowly, but the time required it is more than 24 hours. The prothrombin complex concentrate 25 to 50 international unit IV it is given. It is administered as a 10 minute to 1 hour infusion, and it takes about 15 minutes for the reversal of the effect. The PCC should always be administered along with the vitamin K. The prothrombin concentrate complex available, it contains heparin and it should be used or avoided, used with caution or avoided in patient with heparin-induced thrombocytopenia. If PCC is unavailable, then FFP can be used 10 to 20 ml per kg, but it has got its own limitations with poor left ventricular function patients and volume over to avoid the volume over. Direct acting anticoagulants, they have got their own specific reversal agent, idarucimab and andexanet alpha. These are the two agents. These can be used to reverse the therapy. Andexanet alpha, it is not recommended for reversal in cardiac and vascular surgery patients because it has got interaction with the heparin. It either delays or interfere with the actions of the heparin, as well as heparin also interfere with the reversal effect of the andexanet alpha. Now, patients with antiplatelet treatment, can we reverse? Clopidogrel and prasugrel fresh platelet transfusion can work, but for ticagrelor reversal, as we have seen that it is reversible blockage of the platelet. Within first 24 hours of the ticagrelor therapy, if we transfuse with the platelet, the soluble ticagrelor acts on the freshly transfused platelet and it makes it ineffective transfusion. The neutralizing the ticagrelor, we can use as a cytosorb absorber during the cardiopulmonary bypass to reduce its level and reduce the bleeding risk. Use of neutralizing monoclonal antibody fragment can be promising future. Now coming to the chart to interruption and the bridging, we will see major of commonly used drug warfarin for minor surgery, discontinue 3 to 5 days before the surgery. For major surgery, discontinue. And reinitiation, it is started 24 hours if the bleeding risk is minor. For the rivaroxaban, 24 hours is sufficient for minor surgeries and 48-hour discontinuation is preoperatively for the major surgeries. Reinitiation can be started in 24 hours provided renal dysfunction is not there. Same is about the endoxaban. For dabigatran, it is a little more the 72-hour withhold for the minor surgeries and more than 125 hours, that is 5 days for the major surgeries to interrupt the treatment. For aspirin, every guideline has said that ideally you can continue the aspirin treatment. For clopidogrel, it is 5 to 7 days. For prasugrel, it is mandatory 7 days interruption preoperatively, and ticagrelor 3 to 5 days is sufficient. The chart itself shows how to stop, when to breach, consider, and for the VKS, DOAC, and antiplatelet treatment. Now, though we have discussed all this, we have missed the major chunk from our anesthesia group, that is the regional anesthesia. I recommend due to shorter time, I recommend every one of us to go through these guidelines. These guidelines are released recently last year by European Society of Anesthesia and Intensive Care and European Society for the Regional Anesthesia. The guidelines gives 40 clear-headed recommendations for antithrombotic drugs in patients posted for the regional anesthesia. These are 40 recommendations, and I recommend everybody to go through it. Today, due to shorter time, we are not going for this part of the presentation. Thank you.